Advocacy Symposium. For those who don't know, the Children's Institute is part of the Department of Pediatrics, and one of the things that they do every year is to produce the South African Child Gauge. They're here this morning to talk in the context of advocacy. But one of the most amazing tools for advocacy is data, information, and a whole set of expert opinion. And so Maylene Shung-King will be from the Department of Public Health, but very close and long links with child health and pediatrics. We'll be introducing the team with Laurie Lake, Mike Hendricks, and others to talk about the Child Gauge 2019, which was entitled Child and Adolescent Health, Leave No One Behind. Maylene, welcome, and over to you.
So let me just welcome everybody here this morning. Good morning, everyone. Good morning. I hope you're all well and wish you a very good 2020, even though we're well on our way already. So thank you very much to Andrew and the department for affording us this opportunity. I am Maylene, as he explained, and so this morning we're presenting what has become, and it looks like this year, a flagship product, not just for the Children's Institute and the Department of Pediatrics and Child Health, but also for the university and the country, because since 2005 we've been producing an annual Child Gauge. So this is the 14th edition, and every year the Child Gauge is intended to provide an up-to-date commentary and analysis of the situation of children in South Africa. It focuses on a different theme every year, and the 2005, 2006, 2009, 10 editions, so 3 editions, and a focus on child health. And then 10 years after the last focus on child health, in 2019 last year, we focused on child health again. And it's part of the Children's Institute, as Andrew said, part of the Children's Institute's outputs. And the Children's Institute has specifically been established a number of years ago. It's actually been around since 1995 to bring evidence to bear on advocacy efforts, policies, programs, and services for children, so that we have up-to-date evidence that informs the development of policies and programs and laws and services for children. And so it has bearing not only on the health sector and those of us who work in it, but also for other sectors that are fundamental to child health and that should be considering the impact of activities in those sectors on the health of children and adolescents. So when we say child health this morning, we talk about the health of everyone between the ages of, well, from birth, or actually before birth, to age 18, as per the definition of a child, and so it includes adolescents. So when we say child, we actually mean children and adolescents. So the presentations this morning will take this format. Laurie Lake, who's one of the editors of the Child Gauge, and in fact is the anchor editor for all the gauges that appear. She will first give an overview of what is in this year's Child Gauge. That presentation will then be followed by Michael Hendricks, who's a pediatrician in the department, and he was also one of the editors of last year's Child Gauge. And he will focus on nutrition, which is an enduring challenge for South African children. Both the issue of undernutrition, malnutrition in its various forms, and he will specifically talk about the rising epidemic of obesity and the implications of that. And then hopefully our colleague from the Department of Public Health will join us to talk about another emerging challenge for child health, and that is climate change and environmental health and the impact that that has and the implications for child health. So we had to obviously decide what to focus on for these presentations, and it's not easy. So Before I go further, so the editorial team for this year's Child Gauge is Laurie Lake, Michael Hendricks, myself, and our late colleague David Sanders. Professor David Sanders, whom some of you might know very closely and intimately, and he's been a friend and a colleague to many of us over many years. Started out as part of the editorial team for the Child Gauge, and he sadly passed away 9 months into the production of the Gauge in September last year. So it was a massive loss for us. And so this morning, as we do every time we present the Child Gauge, we want to pay a specific tribute to Prof. David Sanders and his lifelong work that he has contributed to the pursuit of equity, social justice, and in particular for children. And with David, there were 4 things that he never, ever, ever failed to focus on and to mention. The one was the issue of equity and the importance of being mindful of the huge gap that we have in our country between rich and poor, rural and urban, and various other parameters of inequity. He never failed to mention the absolute importance of social determinants of health, meaning that there are determinants that sit in other sectors that impact profoundly on health. So the way our economic policies work, our labor policies, our education system, social welfare, etc., all influence health. And in turn, health and good health influences what happens in other sectors. The third aspect, which he didn't ever make us forget, is the incredible potential role of community health workers in mitigating many of the preventable conditions that children and families experience, and the absolute fundamental importance of that. And then the last aspect, and that is the aspect that Michael will speak to, he devoted much of his life's work to the pursuit of good nutrition for children, because nutrition is a fundamental aspect of child health, without which we will never be able to attain the kind of child health indices that we hope to get. So Michael will touch a little bit on that. So then, without further ado, and paying tribute to our colleague David Sanders, and we fondly remember him in all that we do in relation to children, I'm going to hand over to Laurie to do the first section, which is an overview of what is in this year's Child Gauge that I just showed you. This book over here that weighs probably about 2 kilograms, I think.
So I would just like to start by thanking over 70 contributors to this issue of the Child Gauge. So just to recognise that this is really a collaborative effort that extends beyond UCT across the country. And in particular this year we've included a whole series of case studies, examples of innovative and promising practice from the ground, some of them located within health facilities, some of them located in communities and schools, that talk to the need for innovation and will hopefully inspire readers to lead for child health wherever they are. This cover that we chose for the South African Child Gauge is specifically meant to disrupt kind of assumptions that we have about child health. Very often our orientation is centered on hospital-level care, facility-based care, and we tend to forget where the children come from. And even when we're thinking about rural health, we're often focusing on what's missing and multiple levels or aspects of deprivation that children experience. And yet this photograph captures the incredible energy that children bring with them, and they're inviting us to meet them halfway and to honour the promising potential that they bring. So just a reminder that child health is predominantly driven by factors outside the healthcare system. This issue of the gauge is, in a sense, structured into 4 parts. The first chapter provides an overview of the status of child health and emerging priorities. The following 3 chapters start to unpack what is called a life course approach to health, and explain why it's so important to intervene, especially during the first 1,000 days of life and again in adolescence. And then we've identified 5 pressing challenges. Some have been intractable problems, such as nutrition that we struggle to grapple with, and others are new and emerging, growing burden of children with long-term health conditions, a growing recognition of the impact of mental health, and environmental health and climate change. And then finally, in the last two chapters, we start to consider what are the implications then for us as a healthcare system. How do we create healthcare facilities that are far more attuned to the needs of children and families? I'm going to do my best to go through this as fast as possible because I know there's a series of presentations that are coming afterwards. So we begin with children's right to health. And for us in the Children's Institute, this is always a starting point of our work and a set of guiding principles that should inform the design and delivery of healthcare services. And we know that children in South Africa have a right to basic healthcare services, but they also have the right to privacy, to education, to family care, and to an environment that is not harmful and adequate nutrition. So we're really needing to grapple with all these different rights that are interdependent and indivisible, and to use children's best interests as a guiding principle when we're making any kind of decision about policy or program or service that impacts on children. And there's a fantastic piece up front of the page, written by Louis, that looks at children in the NHI. And in the NHI, this right to basic healthcare services is affirmed. But nowhere have we started to begin to describe what an essential package of care would look like for children. And until we do that, it becomes incredibly difficult to hold government accountable and or to put adequate budgets and resources in place. If we look at the status of child health, we know that we've made incredible progress, particularly in undefined mortality, but equally so in relation to mortality of older children. We see mortality for undefined drop from 79 deaths per 1,000 live births in 2004 to about 32 deaths per 1,000 live births in 2017. And yet, yeah, so I mean that sounds good. And if you look at the context globally, you start to see how children in Africa are left significantly farther behind. And as much as we in South Africa are doing well relative to the rest of the continent, we're performing really poorly in relation to other similar low and middle income countries. So there's a lot more work that needs to be done. We then take a look at coverage of care, and again you start to see a pattern of progress over the last 10 years. But if we look, for example, at immunisation, we're still looking at about 61% of children, well, 61% of children immunised, and this incredible gap with an intervention that's supposed to be fundamental and basic to child health. Similarly, we see a whole series of lost opportunities with antenatal care. We've got extremely high coverage, about 94%, but early antenatal care is poor. Similar pattern if we're looking at postnatal visits where there's a gap in coverage, and again if we're looking at breastfeeding. So good at initiating breastfeeding, a lot less effective in sustaining breastfeeding for that critical first 6 months of life. And then similarly we're looking at significant limitations in young people's access to contraception, and that obviously has an impact on the next generation of children. We see a similar pattern emerging with HIV. There are areas of good progress, particularly looking at the role of PMTCT. If we're looking at HIV incidence amongst young people, and yet when we start to look at HIV prevalence amongst pregnant women, there has been little change over the last 10 or 15 years. And that's driving a growing burden of children who are HIV negative but HIV exposed both to HIV and to ARV medication. But there's clear indications that those children are not doing as well as they should be. So there's a real need to shift attention to early intervention, to prevention in adolescence, where again we have a significant gap in coverage. We then take a look at the social determinants of health. So we take a look at poverty, access to services, children's care arrangements. Again, we have seen a significant shift over the last 10-year period. But there's some critical gaps, some areas where we're simply failing to move or to shift. One of them is in relation to co-residence. So many children still living without a mother, without a biological mother, so living in the care of families. And there's an indication that those children may be more exposed to abuse. And then high levels of children, young people who are not in education and employment, and no change in the number of children living in informal housing. So there's still work to be done. This is just taking a run through the current status. So we're looking at 60% of children living below the poverty line, 30% who do not have access to water on site, 18% living in overcrowded households. So it's not surprising that we're still seeing pneumonia and diarrhea as key drivers of under 5 mortality. We're looking at 20% of children travelling more than half an hour to reach a healthcare facility. We're looking at 27% of children who are stunted, and that means they're significantly chronically malnourished in a way that impacts on their cognitive development, their learning, and their employment prospects. And 42% of children who have experienced some kind of maltreatment. And these conditions are then further reinforced by an education system that is failing to support children's learning and high levels of structural unemployment. So there's a real sense that young people, instead of emerging at the age of 18, 19, 20 to become productive members of society, that their prospects are limited and stunted, and there's huge concern about what that means for the next generation of children. So who gets left behind? Poverty, inequality is one of the key drivers. Discrimination against certain kinds of children, foreign children, teenagers, pregnant teenagers, which I find. So you've got income inequality, you've got discrimination, geography, so high levels of spatial inequality, so the way in which children in rural areas and informal settlements, their access to services and opportunities again is constrained. And these kinds of patterns of inequality are then intensified by shocks such as recession, such as extreme weather events driven by climate change. And then finally, we need to look at the impact of governance. So poor governance in the form of corrupt officials, unresponsive officials that fail to provide services in the way that they should. And it's children that sit at the intersection of these 5 different circles that are most likely to be left. We need to intervene in each one of those 5 circles to make a difference. And this map is just looking at the current patterns of spatial inequalities. It's a multi-dimensional index, so looking at different forms of deprivation, not just poverty. And you can see how those children living in formal homelands are and continue to be most marginalized in terms of their prospects. So these patterns of inequality personality very, very difficult to uproot and disrupt over time. And one of the reasons for this is that our early experiences, children's early experiences, shape their lifelong trajectory. So there's a fantastic chapter by Shane Norris that unpacks the science, the developmental origins of health and disease, and makes a very strong case for early intervention and investment in child and adolescent health in order to improve outcomes across the life course. So, for example, infants who are starved of nutrients in utero are more likely to experience high levels of obesity and non-communicable diseases in adulthood, and that's where our resources in health are going to disappear. And we actually need to be calling really strongly for investment early on in order to maintain investment in child health and to disrupt this intergenerational pattern of illness and disease. And it's really important to understand the way in which children's environments, their nutrition, their exposure to toxins, their exposure to stress in the form of violence and neglect gets in under the skin and starts to shift that epigenetic code. It starts to shift the developing pathways, neurological pathways in the brain in ways that may be very difficult to change later in life. So very, very strong motivation for early investment. The next chapter focuses on the incredible work that the Department of Health has been doing in the first 1,000 days. It introduces the Nurturing Care Framework, which is shaping our global response to children. It's calling not just for an investment in health and nutrition, but also early stimulation, responsive caregiving, and safety and security, so a much broader conception of child health as a foundation, and a very, very strong call to partner and work side by side with parents, families, and caregivers. So it's really calling for a fundamental transformation in the way in which we deliver healthcare services. Similarly, if we look at the chapter in adolescence, there's a focus on how do we build resilience in adolescence, where again, young people are exposed to multiple challenges. And that's sort of everything from a lack of economic opportunities to violence to HIV. And again, there's a call for an intersectoral response. Sorry, I'm missing my other slide. And what's very clear from that chapter is we need to make investments and develop combined programs that bring together elements such as cash transfers, so some kind of income support, safe schools that create an enabling environment, a safe space for young people, together with parenting programs. And when we put all three of those program elements in place together, we start to see significantly higher returns on our investment. There's then a fantastic chapter led by Tony Westwood and Lilo Fleming that takes a look at the needs of children with long-term health conditions. And it's really calling on us to look beyond their specialized needs for care and to recognize again they have complex needs that extend beyond medical treatment, and that we need to find ways to provide that routine care much closer to home. We need to improve communication, coordination, and really bring the child and family into the conversation so that they are able to play an active role in their own health care. The next chapter is led by Shanice Matthews and Ashley Fanichek, and they're looking at violence and injury, and they're looking at where the intersections between violence and injury. Very often they're addressed in very different ways, and it is not always clear where to draw the line. What is an injury? What is unintentional what point does it become intentional? To what extent are healthcare providers interrogating the circumstances in which children are injured and taking steps to ensure that they are not exposed to similar risks on the one hand, and making sure that those children are not just provided with medical treatment, but we're also addressing and responding to the trauma associated not just with violence against children, but also accidents such as this. So again, a call to address mental health. The chapter also takes a look at the recent constitutional court judgment that effectively prohibits corporal punishment in the home, and it introduces us to the work that Kathy Ward is doing to develop parenting programs that equip parents and caregivers with the skills they need to discipline children in a positive way without using violence. And we know that these kinds of interventions are not just good for children here and now, they disrupt again an intergenerational pattern of violence. So if we're interested in preventing violence against women in adulthood, we need to start here with children. And I think, well, that's nearly me. 1 minute to go. And then following chapter focuses on investments in child and adolescent health. So we need to recognize that most mental health conditions have their origins in adolescence, many with the onset already established by the age of 14. We don't know what the national prevalence is of mental health conditions, but in the Western Cape we're looking at 17% of young people. And yet there are only 3 psychiatrists, child psychiatrists in the public sector. So there's a real question we need to ask about the provision of mental health services to children in a context where poverty and violence is so widespread. And I think we're going to end it there and hand over to Michael, who will take us through the nutrition chapter. Guys, perhaps just to say in relation.
Okay, so chapter 8 is in the Child Gauge of 2019, is the nutrition chapter. And the late Professor David Saunders was the lead author on this chapter. And this was his passion. And I would like to acknowledge his contribution and his many insights into this chapter. And then I would also like to acknowledge all the co-authors of the chapter as well as of the case studies. The chapter focuses on the triple burden of malnutrition, so undernutrition, overnutrition, and micronutrient deficiencies, and it looks at the causes, policy implementation, and key recommendations. These are the main aspects that are covered in the chapter, and I really don't have time to go into great depth. I really want to just focus on some key principles. I understand I've got about 10 minutes. So if we look at the contribution of undernutrition to under 5 mortality, you see that this is taken from the COMIC report of 2017. Malnutrition or undernutrition contributed about 4% to the overall under 5 mortality. But this does not take into account undernutrition in children dying from neonatal conditions, gastroenteritis, pneumonia, and all the other conditions that are outlined. Outlined in this graph. If we look at the Child Healthcare Program of 2018, then severe acute malnutrition and moderate acute malnutrition accounted for almost 50% of the deaths of children. So there's a strong association between child mortality and malnutrition. These are just some of the nutrition indicators from 1999 to 2016. And we see that South Africa, just like other low and middle income countries, is facing a triple burden of malnutrition. There has been a decline in acute malnutrition or wasting, but we see that in children 1 to 3 years of age, stunting has been persistently high for the past 20 years and is currently estimated to be about 27%. Overweight has increased. It's about 13.3%, and this is double the global prevalence of 5.6%. Vitamin A and zinc deficiency are more than 40%, iron deficiency 10%, and iodine deficiency 15%. If we look at progress that has been made towards achieving the WHO targets, then certainly in terms of wasting, we have achieved the target of WHO for 2025. The targets for the other conditions here, for example, there needs to be a 40% decline in stunting by 2025, a 20% increase in the exclusive breastfeeding rate, and a 50% decline in low birth weight, as well as in anemia in women of reproductive age. And there are concerns that these targets will not be met by 2025. So what are the main drivers of under and overnutrition? So this is just taken from a recent publication in The Lancet by Hawkes et al. And we see that there are common drivers for both under and over nutrition. If we look at the first one, early life nutrition, we know that nutrition during pregnancy and lactation and in the early years of life has profound implications for malnutrition during the life course. For example, if the mother has inadequate nutrition, this could lead to low birth weight in the infant, and these infants are then at risk of developing overweight, obesity, and diet-related non-communicable diseases later in life. I would like to explore some of the other drivers. We know that there's a relationship between stunting and overnutrition. And if we look at the data from the South African Demographic Health Survey, as mentioned previously, there are very low rates of exclusive breastfeeding in babies under 6 months of age. And these rates actually drop with increasing age over the 6-month period. So that by 4 to 5 months, only 24% of babies are exclusively breastfed. We know that breastfeeding is protective against undernutrition as well as overnutrition, and that it has a number of other advantages in terms of enhancing cognitive function and stimulating immunity. Only 23% of children in the South African Demographic Health Survey were found to receive a minimum acceptable diet between 6 and 23 months. And if one looks at the graph here, you see that the rates of stunting actually increase over this period of time. Of concern was that a third of children under 2 years consume sugary foods and drinks and salty snacks. And there's also a very close link between poverty and undernutrition or stunting. So stunting was found to be about 36% in the lowest wealth quintile compared to 13% in the highest wealth quintile. Moving on to the food system. The food system includes the infrastructure and processes from the production to consumption of food. And at a global level, there are global food companies that produce ultra-processed foods, which are high in sugar, salt, and fat. and the marketing and sale of these ultra-processed foods happens in poor communities and contributes to the increasing rates of overnutrition. I've been told I've got about 3 minutes. So I think in the publication in The Lancet, because there are common drivers of undernutrition and overnutrition, double-duty actions have been proposed that aim at simultaneously preventing and reducing the risk of overnutrition, undernutrition, and diet-related non-communicable disease with the same intervention program or policy. If one looks at some of these dual actions, they include scaling up of antenatal care, so promoting healthy eating, physical activity, and micronutrient supplementation for all pregnant women, as well as supplementation with energy and protein of undernourished mothers. Scaling up the protection and promotion and support for breastfeeding, and that means ensuring that mothers who leave birthing units are supported to breastfeed through the health service, as well as through community-based programs. Guidance on complementary feeding, covered in our Road to Health book, the IMCI strategy, the redesigning of growth monitoring and promotion so that it doesn't only address undernutrition, but also overnutrition, so the detection of children who are overnourished and appropriate counseling. And then preventing harm from energy-dense foods, ensuring compliance in terms of fortification, but also making sure that energy-dense supplements, like ready-to-use therapeutic foods, are used for their intended purposes by other members of the household. We need guidelines and standards on healthy meals in schools and ECD centres, and we need to regulate unhealthy foods through tuck shops and vendors. Possibly looking at increasing the child support grant to include a nutritious basket. And then in terms of the food system, restrictions on marketing, ensuring that the sugar tax is implemented, nutrition labeling, and then providing incentives for retailers and consumers for the sale and purchase of nutritious food. Now, many of these dual actions can be implemented through existing programs, but we need to look at why these policies and programs are not working and how we can actually improve the implementation of these programs. And a lot of this is covered in the chapter on the gauge. So in conclusion then, we are faced with a triple burden of malnutrition, high rates of stunting, and rising rates of overweight. There are common drivers of under and overnutrition and dual actions that can address all forms of malnutrition. But we need more effective policy implementation and integration through the different delivery systems. Thank you.
Thanks very much, Martha. It's 10 minutes on the dot. So may I introduce Andrea Groffman, who is from the Department of Public Health and Family Medicine, and she'll be talking to the chapter on environmental health and climate change.
Thank you, Maylene, and hello to everyone, and good morning to you. So I'm assuming that you have all got a copy of the gauge. It's on your desktop. You've got a hard copy. Sorry. It's just the last one. So you've all got a copy. You've got 10 minutes before you move on to your next activity. You're flipping through it and you decide you're going to quickly look at the environmental health chapter and what is it about. And in 10 minutes, what are the 3 key messages that you should come away as a clinician, as a health professional, from the environmental health chapter? So I'm hoping that I'm going to guide you through that. So your first take-home message is about assessing patients for environmental exposures as part of your routine diagnostic tools. And are you already doing that? Are you doing environmental history taking? And why? why should we put environmental factors and environmental exposures more on the table of health professionals and clinicians? Well, when you look at the chapter, you'll see that we have high exposures. I gave the example of air pollution as the new tobacco. But what about chemical pollution? And what about other forms of pollution as well? We're also seeing an epidemiologic transition. So we focused a lot of our education on looking at infectious diseases, but there's a transition, particularly in urban areas, and you've heard about nutrition issues, going from communicable diseases to non-communicable diseases. And many of these are from environmental exposures, and as you'll see, also from climate change, and there are a lot of climate-sensitive NCDs. Also, there's a limited awareness about environmental health factors. So ask yourself, what were you exposed to this morning? Are you aware yourself what environmental exposure you had? What chemicals were in the creams you put on? What chemicals were in the cleaning materials you used? What chemicals are in the clothing that you wear? Are you yourself aware of it in order to assess it from your patients? And that prevention and policies are quite poor in South Africa, and particularly for children. We do not benchmark our policies to have a goal for children's health, particularly from environmental exposures. So very quickly, environmental health is a multidisciplinary field, and if you can see, there are very broad spectrum exposures that we classify as environmental health factors. So whether I mentioned chemicals or air pollution, we've heard about nutrition and water, built environment. For example, you might have a patient who brings a child in, and have you asked a question to see whether they've been crawling on the carpet? Is it a new carpet? Is the glue underneath the carpet off-gassing, causing respiratory problems in this child, or causing perhaps dermatological impacts? So the built environment has quite an effect. I don't know how well you can see that, but this hopefully will entice you to look at the chapter to see the more detail and the broad spectrum of environmental exposures that impact on disease. So if you can see how they're classified, I'm not sure is that very visible. So there's injuries, non-communicable diseases, and looking at respiratory infections, diarrheal infections, vector-borne diseases, etc. I mentioned that some of the non-communicable diseases are climate sensitive, and this is coming out more and more in the data. When I was listening to Michael's presentation, a lot of the research now is coming out on the climate impacts on nutrition, both on obesity and undernutrition. And taking into account then when you're seeing patients, what are the climate impacts? And particularly the one that we're interested in quite a lot is looking at the mental health effects. So we have flooding, or we've had fires that burn down shacks, and what are the mental health effects on children? And how does that present itself, both in schools, in behaviors at home? What about the temperature increases that we experience? And there's a direct association between violence and temperature increases. Are we then taking into account when we're seeing patients during a hot period of time? I'm assuming that you're all quite familiar with this, but particularly in environmental health, the issue is the windows of vulnerability. We've already heard about epigenetics and children being exposed at different time periods to different environmental factors over their life course of their life, and the impacts that this has. And how do we then look at interventions within those different time periods? How many of you do environmental history taking as a routine? You have a patient who presents, I've got one, thank you. The patient presents and you ask specifically environmental health questions. What chemicals do you use at home? What products do you use? What occupation do you have? What was the child? Where does the child stay during the course of the day? Do I only have one person who asks those questions? Two, thank you. So it is key and vital for environmental health that part of the routine diagnostic tools that we rule out is the repeated asthma case that's coming in and I'm prescribing an asthma pump for actually because there's mold in the home and I haven't informed the patient that they should be removing the mold from the bathroom that the child's being exposed to. But if we ourselves aren't aware of these issues, it's difficult to make those associations. And the difference between adult environmental health history-taking questions and children. So your second take-home message from this chapter is about communicating environmental exposure risk to the patients and our patients so that they can also prevent it. I gave the example of mold. And the problem that we have is it's very difficult for us to give advice if we haven't had training ourselves. So one of the recommendations that's come out of this chapter is that we need to improve the medical curriculum within South Africa. Not only South Africa, it's a global issue that environmental health and climate change aren't featuring. Often students don't see the association between the chemicals in the plastic bottles that they're drinking and maybe health effects that occur between the lead that's in lipstick or mercury that's in skin lightening cream. If you look at the curriculum at UCT at the moment, this just gives you a quick overview that basically in 6 years of education, you get 2 hours of environmental health and climate change training. Specifically focused on children is very limited because in 2 hours you can't do a lot of that. We're trying to work to get more in the curriculum, but herein lies the problem. And those of you who've already come through the curriculum, now it's up to you to do self-education. And I'm hoping that the chapter, those 10 minutes, when you look at that chapter, that you'll actually be invited and intrigued to say, hang on, I have this patient who keeps presenting with this health effect. Let me actually go and see if there's an environmental exposure that I'm missing. So some of the lessons that we've learned is that we need to have drivers. We all need to be a driver about the curriculum. We need to have the passion for it. And we need to be showcasing the burden of disease linked to environmental factors. And we need to entice the next generation. The young people who are coming through and who perhaps aren't interested in public health or environmental health, to see the association between clinical work and children that are presenting, as well as the environmental exposures and the health effects. So our challenge is, how do we make students excited? How do we bring environmental health and children's health into continuing education? And the child gauge is a good example for that. I really do hope all of you have the PDF on your desktop and that you're using it for teaching. So take home message 3. What is clinicians' role in nationally and internationally preventing and controlling child and adolescent diseases linked to environmental health? You can contribute to surveillance data, but if you're not diagnosing correctly, if you're not putting enough details in the case reports that you fill out linked to environmental issues, or potentially that there was a pesticide used, or potentially it was the cleaning material, then that data is lost. And internationally and nationally, we have no idea of what health effects are happening related to children and adults being exposed to environmental issues. You can also write articles, get more motivated, and contribute to the media. So those were my 3 messages that I've left you with, and I hope that you will pick up the child gauge and think about those, and start by being active and get on Instagram. I've left a few posters and magnets lying around about promoting people to phone if there's poisoning, and your role that you play in diagnosis, prevention, and treatment. Thank you.
Thank you very much, and I certainly learn something every time, because a lot of the time I'm not cognizant of the issues that you just raised, so thanks for raising them. So in the last few minutes, I would have liked to get some audience participation, but I think time is against us, and hopefully, Andrew, you can invite us back for another session to debate the last two chapters of the child gauge, and of which I will highlight issues on one of them. And the last two chapters focuses on what does it mean to put children and adolescents at the heart of the health system. And that chapter was incredibly difficult to write because there's so many facets to consider. And we really struggled to put those facets together. And Tanya Doherty, who's sitting in the front here, was one of the co-authors on that chapter. And then the last chapter was to consider and think about what does a health workforce for child health look like. And when I say child health, again, I mean child and adolescent health. So I'm just going to reflect on a few points that arise out of those chapters, and of course there's many more things to consider. And the reason why I hope that we'll be able to come back, because we were hoping that we'll use the chapter on putting children and adolescents at the heart of the health system as a debating point, where we then would have a series of dialogues across the country and come up with a consensus of what our health system should look like. So I just want to make a few points. So firstly, I think that Laurie had already alluded to, that children and adolescents are the demographic foundation of the country. They make up almost 40% of the population. They have specific constitutional entitlements given to them. So we are obliged, morally, ethically, professionally, and constitutionally, to foreground children and adolescents in everything that we do. But one of the first points that would put children and adolescents at the heart of the health system is to recognize children's agency and their right to participate in health issues that affect them. And we have a brilliant example that's highlighted in the gauge from this hospital. As you enter into outpatients, there's the RX radio booth that does some fantastic work on enabling child participation in matters that affect their own health. And Gabriela Goiti wrote a lovely case study that we used in that. So firstly, to recognize that children have agency and that they can participate, and that they should be seen as equal partners in the clinical interactions that you have with them and with their parents. And even if children are a little neonate, they still are entitled to be considered as an equal partner in that health interaction. Of course, it's different in the way that you interact with an adolescent to a neonate, but it's important to consider that we don't just have the right to stick a needle into a neonate without actually taking into account how the feelings of that little baby. The second thing is that child health is not just the responsibility of child health specific programs, services, and directorates, and that child health needs to be foregrounded in every facet of the health system. So just very briefly, a health system is not just about health services, but it has a finance component, it has a human resource development and capacity development component, it has engineering, it has infrastructure, etc. It is also concerning other sectors that impact on health. It also concerns the variety of activities and interventions that happen in communities. So when we want to foreground child and adolescent health, firstly we must have a very clear vision for the country. So it's not a vision for child health proponents, but it's a vision of the entire Department of Health. And until we have a very clear vision, we will struggle to foreground children and adolescents in the health system. And so far, we don't actually have a very clear vision. And so all of us should be lobbying and advocating to have that clear vision. Secondly, we need to have a very explicit and a properly resourced and funded basic healthcare service package for children. It's already 5 years since the Constitution was launched. We still don't have that clear package. We need to continue advocating and lobbying to have that clear package, without which we will struggle to foreground the needs of children and adolescents in the health system. Thirdly, it has to be considered in the way that we put budgets together. So when the Minister of Health puts together the budget for the country, and every province puts together their health budget, and every district puts together their health budget, and every facility puts together their health budget, children and adolescents' health needs must be at the center of those budgets. The way that we think about the training and development of the human resources and the health workforces in the country, we have to think specifically about how we are equipping every single person, whether they will be working in a child health specific service or not, to understand the needs of children and adolescents and to at least be cognizant of the issues that affect children and adolescents. And until we orientate our health workforce in that manner, we will struggle to adequately foreground children and adolescents in the health system. So foregrounding children and adolescents in the health system is more than just developing child-friendly services where we have friendly protocols and guidelines, baby-friendly hospital initiatives, child-friendly services. It requires every facet of the system to consider what their actions and activities mean for the promotion of child and adolescent health. So it requires that everyone has to be aligned together towards a common vision which we need to develop as a matter of urgency. And not only that, it's also our responsibility to collaborate with our colleagues in other sectors to ask them to consider every time they develop a particular policy, even around business, social welfare, education, how that might impact and what the implications are for child health. And until we get those activities aligned, the social determinants of health will continue to undermine our ability to attain optimal child and adolescent health. So again, when we've got wonderful examples where major infrastructural projects were developed. So there's a beautiful example of a hospital in the Eastern Cape that has the most fantastic child and adolescent friendly ward that I've ever seen, where children's right to play even though they are ill, the parents' right to visit their children and to stay with their children for as long as possible, etc., were taken into consideration in the design of the hospital. And so, for example, in this faculty, we've struggled to get breastfeeding facilities for breastfeeding moms as dedicated spaces. And even in our School of Public Health, which is a proponent of breastfeeding, we struggle to get a dedicated space. So in all of these kind of infrastructural facets and every absolute component of the health system where planning and resource allocation and activities happen, children and adolescents must be considered at the forefront as an important part of our constitutional obligation to them, but also our moral, ethical, and professional obligation to children and adolescents. And so that's all that we've got time for now. So I'm going to ask you, as you go away, to discuss among one another and to consider for yourself what you think your contribution could be to make sure that we foreground children and adolescents in a meaningful way in what we do. And if you have any thoughts that you'd like to share with us, please email any of us. It's the easiest email to give you is lori.lake@uct.ac.za. We'd really like to welcome to hear your thoughts as to how you think we could develop a health system that puts children and adolescents at its very heart. So that we have this, when we have this conversation again in 5 years' time, we would have made significant progress. So thank you very much for your attention. Thank you to all our speakers, and thank you to the department for the opportunity.
Thanks very much, Maylene, and the whole team. I think, as always, you've stretched our understanding of what we need to take in mind and learn about. Perhaps I can just ask you to download the PDF. What do you do? And how much do you pay?
The PDF is available on the Children's Institute website. That's www.ci.gct.za. That's freely available together with, there's a fantastic poster that is starting to look at this question of what some of the elements of a child and adolescent-centered healthcare system might look like, and maybe that's a useful starting point for some discussion. I have 17 copies here, hard copies here, and if you want a hard copy, you'll need to sign for it. If you'd like to come and collect a copy from the Children's Institute, you're more than welcome to do so. We don't charge for the materials, but we did a very limited run of 2,000, so they are incredibly precious. But you are the core audience, and these are child hearts.